Okay, welcome everybody. We're just about ready to start, but let me just give a few webinar reminders, particularly for those of you who haven't used webinar by Zoom. And it's our first opportunity to do so as well, so hopefully we won't have glitches. But please be aware that you are going to be muted throughout the webinar. There's a chat feature at the bottom of your screen, and you can use that chat feature if you need to ask a question or to contact any of us here. There will be an opportunity for questions during the discussion and question portion of the program. We can actually chat. And the webinar will be recorded and the slides will be posted on cardio.org and in Box for those of you who are signed up with us. So today's webinar is entitled Like It Is, Real World Applications of the DASH Diet for Low Income Populations. And I'm here with, I'm Michael Constant, and I'm here with the co-PI of Cardio, Sherry Boland. And we're pleased to welcome all of you. Today we have over 140 participants that are signed up today. We have our number of national nonprofit organizations, so American Heart Association, American Medical Association, YMCA. They're on the phone or in the webinar. We also have state and local public partners, the Ohio Department of Medicaid, who funds Cardio, as well as the Ohio Department of Health and the City of Cleveland. We have our 6 Ohio managed care plans. We have 7 health systems. We have 3 health centers on and other Medicaid providers. And we even have Pfizer from Pharma who's on as well. So quite a nice representation. So thank you for joining us today. I have 2 other housekeeping things. We are offering continuing medical education for this program for 1 hour. It has to be completed within 2 weeks. You will be receiving an email about that. If you don't, we do have the attendee list, but we'll make sure that you get an email in order to apply for your CME. We have a pretty packed agenda, which is why I'm speaking fast. Again, welcome to all of you. We're going to start with Sherry Boland, who will give an update of some of our cardio activities. And that will be followed by Gautam Rao, who's going to give an update on Project Echo. And then the main part of our program is surrounding the DASH diet. Adam Przezinski will be presenting the social determinants of health with regards to the DASH diet. And he'll be followed by Randy Wexler, who's going to talk about some real world applications of the DASH diet. Then Adam will facilitate discussion and questions. And then Sherry and I will do a fairly quick wrap up. So hopefully we'll have time to get all through of those. Again, Zoom webinar logistics, submit questions using the chat features. If you want to speak during the discussion session, to be unmuted, you need to let us know. So you need to put that in the chat to the panelists. We will have some poll questions that will be put up. You'll have 15 seconds to respond to those before we provide what the survey results look like. And then we'll also be distributing a post-webinar survey that we'll share that link at the end of the webinar, and we'll also send that out by email. That will help us provide the best programming for all of you. So with this being a CME activity, we do want to outline the main objectives is to describe Cardio's goals and activities, to describe Project Echo, to identify ways for clinicians to support low-income patients' adherence to the DASH diet, and to identify emerging resources for clinicians to address food insecurity in low-income patients. So with that, I'll turn it over to Sherry Boland, who will give us an update on Cardio. Sherry?
Great. Thanks. Wonderful to have everyone joining us today. And as Mike just mentioned, I'm going to really go through and just give a brief update on where we are with our cardiovascular health collaborative today. So just a reminder that the purpose of our collaborative is really to expand the primary care team's capacity to prevent, diagnose, and manage cardiovascular disease in Ohio's Medicaid population, and to identify and address disparities in cardiovascular health care and outcomes affecting the Ohio Medicaid population. And as many of you know, our initial focus has been on hypertension and social determinants of health, and you'll see some of that featured today. Next. So we're really going to accomplish our purpose as a collaborative by sharing information, learning together, and disseminating best practices. And that's part of what we're going to do today, not only hear from our speakers, but also have some time to share what everybody's doing and learn from each other. We have 7 amazing teams to accomplish our purpose, and I just really want to thank everybody who is on the webinar, who's part of those teams. We have a lot of team members doing a lot of great work. And the update, I think, from this year compared to last year is we have a new team with Project Echo, and you're going to hear from Dr. Rao, who's leading that team, in just a few minutes. And these are the PIs at our all of the Ohio's 7 medical schools. So we're really excited to have all of the medical schools participating in this collaborative, and want to thank the leadership at all those institutions to help bring this great work together. And just to show you a little bit about how we're growing, in March of 2018, right after we had our first in-person meeting last year at our kickoff, we had about 107 team members, or 107 total members in our database, and we had 89 of those that were serving on a team. And then in October of this year, so just yesterday, apparently, we had 182 members, so grown quite a bit, and 133 of those are on teams. And just to show representation, and I know Mike just mentioned some of the folks that are on the call today, but this gives you a sense of some of the representation in our database. And you can see that the biggest or largest growing group between last year and this year were the provider group. And so we have some other groups that we may want to even work on for additional recruitment. And I think all the things that you mentioned, Mike, earlier about who's attending applies here. You can see that those same groups are really represented here, and really lucky to have all of the interest and participation. We've been recently talking with the National American Heart Association as well, and they've joined our call today, and as well as our local AHA partners. So, so you can see this list is a great wealth of partners, and I'm really glad we can make a difference together. So next, this is the first of the interactive portion of the webinar. So you're going to have 15 seconds to answer this question. Are you part of a clinical team that serves Medicaid patients? So I want to hit yes, no, not applicable, and as I don't know if they have to hit submit, but it looks like people are figuring that out because you're submitting answers. And we'll end the polling just a second or two. Great. And so what you can see is that about 40% of people are Medicaid providers or see Medicaid patients. And that's really important for us because part of this is to understand our reach to different Medicaid providers, and something that we can report back and continue to grow on our call. And the next slide. So the last 2 things I'm just talking about is our year 2 scope of work activities. One was to expand our collaborative to encompass the Ohio 7 schools of medicine, which we've done, and really developing that evidence-based content to share in 5 different areas: hypertension, lifestyle management for cardiovascular health, business model for how we implement that in primary care and clinical care, quality improvement coaching, and social determinants of health. And we plan to share that content through local dissemination, Project Echo, webinars like the one we're on today, our website, and our annual in-person statewide conference. And then we're going to really be trying to develop and track success metrics such as the reach of these activities, which we are trying to assess, and align with our hypertension quality improvement project across the state to really share success stories from that with each other and assist with any new content needs for that. So before I switch over to Dr. Rao, I'll just mention the Project Echo Pilot Tele-Echo Clinic. After you hear his presentation, if you're interested in Project Echo, please contact Ann Navar, and she can help connect you and ask or help answer any questions. And we have our 2nd annual statewide conference on Friday, May 17th. So we want you to mark that on your calendars, and we'll send more information soon. And we'll have an upcoming quality improvement webinar with additional details to follow. I'll switch over now to our
Great.
team lead, Dr. Rao.
Thank you, Sherry. And so my job in the next, I think, 8 minutes is to get you excited about Project ECHO. So let me tell you how I got started. So I got involved with ECHO in 2011. So it's almost 8 years now that I've been involved. And I got involved when I first joined the faculty at the University of Chicago back at that time. And I can tell I wasn't really all that keen. They said, "Do you want to get involved?" I thought it was a CME program. I said, "I don't really want to do CME. And how many people can you possibly reach if you're on a video conference?" It sounds very, very low impact. My views changed very quickly when I learned about ECHO. So can we go to the next slide? So it stands for Extension for Community Healthcare Outcomes. It was developed at the University of New Mexico by Dr. Sanjeev Arora. And essentially it uses technology to leverage scarce resources. So New Mexico had some unique challenges in that there were very, very few specialists in that state. They're mostly concentrated in Albuquerque, and it has a large rural population with many needs. And so some of the first ECHO programs were to improve management of hepatitis C, whereby primary care physicians would learn about hepatitis C management from the experts and then implement those practices in their own setting. And of course, by sharing best practices to reduce disparities, you extend the reach of specialty care. This has been monitored carefully, and evaluations have been done that have shown, in New Mexico at least, that hepatitis C management in these community settings is comparable to that in a specialty setting. So applying case-based learning is a key feature to this as well. Next slide. So rather than go into more details of ECHO, we wanted to show you what an ECHO webinar or ECHO session is like. Unfortunately, Shannon was not able to actually obtain the case-based portion of this. I don't know why, but there were some restrictions around that. I think we would need permission from the case presenter, which would be hard to get on short notice. So these videos only show me, but I guarantee you they're much more interesting when you have the presenter and the case that takes place. So the typical ECHO session will begin with a didactic portion that kind of sets the stage for the case-based presentations, which are actually the key part of it. They are interactive. So you'll see some of the key features here. So Rick, we can start that now.
Good morning, everyone. Happy Friday. It's so good to see you.
Good morning.
Good morning. Good morning. Happy Friday. Welcome to the last Friday of October. And we're making our way along in our childhood obesity and comorbidities series. We're actually on our 4th session today. So we're looking forward to a great didactic by Dr. Rao and 2 great cases. Dr. Rao, you have remote access, so whenever you're ready to go.
Okay. Thanks, Nikaya. Thanks, everyone. Good morning. We have a lot of content this morning. There are some significant barriers for screening for lipids in children. Those are both physician and health system barriers, so health professional and system barriers. Lack of knowledge, a lack of belief in the value of screening, that's still pretty common. A lack of identification, who should I screen? How do I identify them efficiently? Lack of knowledge of follow-up and treatment guidelines. So this is a common theme in the whole cardiovascular field. It applies to adults and to children. The more I know about how to treat a condition, the more likely I am to screen for it. Greg's a 9-year-old boy with a history of well-controlled asthma and a BMI percentile of 98. His father is just 42 and suffered an MI last year. It's a really bad sign. Father is a former smoker and he's very, very obese. Average of 2 fasting lipid profiles reveals the following. Total cholesterol 210, LDL is 142, which is high. So I told you, remember those thresholds, 110 for the LDL. 170 for total cholesterol, triglycerides, again, 130, and HDL-C is below 40. Meets all of these thresholds, whether he's age 10 or younger. Doesn't really matter in this case. So what would you folks do? What would be your first step?
Okay, thank you, Rick. And as Sherry mentioned, we're going to start with a pilot series of ECHO beginning in February of next year, and it's going to focus on hypertension, adult hypertension, and with an emphasis on social determinants of health. It'll be 12 weeks long, so this is a typical ECHO series, lasts for about 12 weeks, in which we expect practices to participate on a weekly basis for about 1 hour at a convenient time. Usually that's early in the morning. Of course, not everyone from every practice is going to be there every time, but we do expect at least a couple of representatives to begin there. We'll start with the tele-echo clinic and include a didactic portion. So this is actually a case presentation. Cases are actually solicited in advance, not just because our experts can read up on whatever questions are coming up, which is helpful, of course, but also because I think it sets the stage. We don't want to duplicate questions and issues that come up from week to week, because this is a very, very precious time, obviously. There will be a needs assessment and pre and post clinic surveys as well. So as Sherry mentioned, we are recruiting practices right now, and you can contact Ann about that shortly. I'm very excited about leading this particular part of cardio. I think it's going to be fantastic. We've got a wonderful team here. We have tremendous expertise as well. I should, in full disclosure, tell you my research focus is on pediatric hypertension and cardiovascular risks. And though I care for adults, whenever anyone talks about adult research, it makes me a little nervous. So I'm glad Jackson's here to help out with the adult hypertension piece, because I could learn a great deal as well from that series. I'm looking forward to it for that reason. So thanks very much, everyone. So far, we have drafted our curriculum, and as I mentioned, it focuses to a significant degree on care of underserved populations, especially Medicaid populations across the state. Social determinants of health will be woven into every single session that we carry out, as well as an introductory session as well. We'll talk about the new guidelines. There's some controversy about them that has been circulating for some time. We'll talk about that during the series as well. We want to include a diverse range of urban and rural practices serving Ohio Medicaid patients, which means enrolling practices from across the state, whether they are close to Cleveland, Cincinnati, Dayton, wherever. It's going to be quite a diverse range of participants, because every practice has different needs. So the ECHO program I led was across metropolitan Chicago, which, believe it or not, has about the same population as all of Ohio. But even within that relatively confined geography, you had huge disparities in how physicians would care for patients and resources available to them. So you can imagine across Ohio how much diversity we'll have as well. And that's a very important part of our ECHO series. Thank you.
Great, thank you so much, Dr. Rao. I'm going to move on to Dr. Brzezinski, who is one of the two co-leads for Team Best Practices, to have us get started on some of our content for today.
Great. Well, thanks, Sherry, Mike, and Dr. Rao. So as Sherry said, I'm giving this in my role together with Jackson, leading Team Best Practices, where we're going through a process of collecting and reviewing evidence. And so today I'm going to give a sort of brief, what I would describe as a lightweight introduction that sets the stage and gives a picture of the intersection of poverty, food, and nutrition. Certainly there are folks who do very in-depth studies of food systems, and that is not the goal here to describe the detail of food systems, but rather to sort of give a brief introduction to some of the circumstances that affect particularly Medicaid patients in Ohio. The data that I'm going to show you come from two helpful tools, and so you'll have these links after. One, most people know about, it's county health rankings. The other, I think a lot of people are not familiar with, and it's produced by Healthy People 2020, and it's their Data 2020 tool. And it's really a sort of very useful tool that you might find useful for your own work. So I thought I would just highlight that briefly at the outset here. So for the nation, what we can see is that, or relative to the nation, what we can see from this map of food insecurity in a 3-year period, 2014 to 2016, is that Ohio is not in the worst category, but we're in the second worst category. So if we group states, so we're among the most food insecure areas as a state in terms of the percentage of households that are food insecure, and that hovers around like the 15% range. But one thing we know is that states are large and diverse. Ohio is a very large and very diverse state, and so that so food insecurity across the state. This is not food insecurity. This is actually the Food Environment Index, which is sort of different. So food insecurity is whether you can, and Dr. Wexler is going to get into these definitions for you more thoroughly. Whether you can afford your food. And here we're really talking about whether you have access to healthy food in your area. And what you can see is this varies wildly from county to county across the state. But even within counties, so this is our own area up here in the Northeast in Cuyahoga, and what we can see here is that, so this is pretty recent data on what percentage in an area visited a food bank. And we have some neighborhoods in Cuyahoga County where almost 3/4 of the residents visited a food bank. And so those food banks, those are emergency food sources. So these are households who experienced a food emergency recently. And the picture is probably similar for many other counties across the state, where you have some folks who are doing fine, and then you have other folks who are really struggling. One of the important linkages between food insecurity and access to food is income inequality. So the other thing we know is that resources overall are unevenly distributed across our state, so that you have places where you have higher rates of inequality, and you have some counties where pretty much everybody in the county is the same. So sometimes when we talk about poverty and inequality, there's some ambiguity. This slide is just to disambiguate that. So for a family of 4 in 2016, the federal poverty level was about $24,000. And we had about 1.5 million Ohioans who met that criteria in 2016. That number is relatively unchanged today from 2016. And to compare with Medicaid, so there are more than that than are on Medicaid. So that means that not every patient on Medicaid is living in poverty, and that's an important distinction for us to think about and make. So not all of your patients live in poverty and are food insecure just because they're on Medicaid. Another important context for thinking about food and resources in Ohio is how people are able to pay for food when they live in poverty, and especially how that has changed over the past 15 years. So really what we know is that there have been, we're pretty stable in terms of the number of families living in poverty, but where we've seen a drop-off that dates all the way back to the 1990s is where those families living in poverty receive support, where they can get cash assistance when they have a need. So if you have an emergency and you need food, there are today fewer resources available to you than there were a decade or two ago. And this is really borne out in the data. So fewer and fewer families now qualify for assistance in Ohio. A family of 3 has to earn just less than $1,000 a month to be eligible. If you meet that threshold, on average, you're eligible for about $400 per month. And of the families who receive those dollars, 90% receive all of their money from the program. So it's not like folks are just making $998 and getting $400. Most of them have $0 and are getting $400. So when we think about food insecurity, we're really talking about folks who desperately can't pay for food. And I think that's, so that's it on the slides about, the state. Now I just want to show you how this looks according to some national trends. And so what we can see here is that it's relatively stable across time in terms of, these are flat lines is the story here, that the poverty threshold versus food insecurity is relatively flat. But what does that mean for people's consumptions of fruits and vegetables? Well, we know that we're missing the target by a wide margin on the portion of a person's diet that consists of vegetables. And that's really actually the same by race and ethnicity, so that regardless of a person's racial or ethnic background, we're all doing pretty badly about consuming enough vegetables. The one area where we do see a difference, though, is this slide on public and on insurance type. And so we actually know, so this is, so it's highlighted in green for public insurance. And so in the most recent data, and this is folks under 65, and really the only public insurer for folks under 65 in the United States is the Medicaid program. So what we know is persons on Medicaid actually, regardless of race or ethnicity, eat fewer vegetables than persons not on Medicaid. There are lots and lots of slides I could show you that are similar, so we could go over fruits and salts and grains. And the story is really the same, so they all sort of look the same, and we'll make those available to you. But across race, ethnicity, education, and income, and particularly among people on Medicaid, what we know is that the proportion of foods that are good, healthy foods, the parts of the DASH diet that Dr. Wexler will talk about that you want to be doing, we're not doing enough of. And the parts that you don't want to be doing, which are salt, lots of salt, and sugar, we're doing too much of. And you know, in general, for diet, Ohio fares the same as the rest of the nation, but that varies wildly by the part of Ohio that you're in. So particularly in the southeast corner of the state, that sort of Appalachian region of the state, where we see with the worst dietary behaviors. And so next up is going to be Dr. Wexler. So Dr. Wexler is going to tell you about some real-world applications of the DASH diet and really dive into like the details of what the DASH diet are, what the circumstances are that people face in Ohio that are linked to the DASH diet. He is Associate Professor of Family Medicine at The Ohio State University, where he's also Vice Chair for Clinical Affairs. And I think he's going to be able to present some on-the-ground perspectives that is really linked to the clinical experience with patients in Ohio, that sort of takes it back and brings it back from the high-level data that I just showed you. So Randy, I assume you're ready to go.
I am, if you can hear me. Next slide. Thanks. So on this particular slide, what you can see is the breakdown of the dietary approaches for the prevention and treatment of hypertension. And these are the therapeutic lifestyle changes that are typically recommended. The one we're going to focus on today is the DASH diet, and we're going to talk about that in a little more depth. But you can also see here that dietary sodium use, alcohol consumption, potassium intake are all very important. I think one of the things that is important, especially when it comes to dietary challenges, especially with those who are unable to, for financial reasons, obtain the foods that we would like them to eat, is to pay particular attention to the sodium reduction, because you can see that cutting down on sodium has almost half the impact of the DASH diet. And actually, as many of you know, the DASH diet with a low sodium diet has reduced blood pressure even further, promoting a further healthy lifestyle. Next slide, please. So what is the DASH diet? Well, it's high in fruits and vegetables. It's high in fruits and vegetables, whole grains, low fat, things that we talk about frequently with respect to what we want people to eat and then what we don't want them to eat. We want people to limit sugar, sweetened foods and beverages. It's interesting how often that patients don't understand that the liquids they consume, the pops and the sweetened teas, contain the calories and things we do not want them to consume. In addition, it has a significant effect on blood pressure, when you eat the wrong foods, but a very positive effect on blood pressure when you consume the foods that we know to be healthy. The DASH diet is recommended by the USDA and is actually, in addition to just for patients with high blood pressure, is considered to be an ideal eating plan in general for all Americans. Next slide, please. So here you have on the left an example of an eating plan. And sometimes that's easier to provide for a patient instead of giving them some of the generic information with respect to grains and vegetables, fruits, low sodium, cutting back on sugars. I think one of the things that's also important is working with patients to try to incorporate this into their cultural expectations for diet. Everybody comes from a different cultural background. Food ties family together. We use food around holidays. We use food to mark important milestones in families. And if we recommend somebody change how they eat without being aware of the cultural dietary importance, then we're going to be ignored. And so it's helpful to try to work with patients within the framework of the DASH diet with respect to their specific cultural needs that are important to them to maintain the identity that is important to them. Next slide, please. So here's some tips. We want to gradually add foods. It's just like anything else. One of the things I always have to tell patients is that the healthier you eat, the more gassy and bloated you might become. And so one of the things we want to do is slowly introduce vegetables over time, same with fruit, for a couple of reasons. One, we want the individual to become used to eating that. But two, and we're going to get into this, there's a significant cost to eating healthy. Lean meats, fresh vegetables, fresh fruits are all expensive. And when we get to the aspect about food insecurity, that will become even more important. Again, when it comes to liquids or beverages, many patients do not really understand or pay attention to the amount of fat or sugar in what they're consuming. So making small changes such as moving to fat-free milk or low-fat milk as opposed to whole milk can become very important. A portion size is important. I'm fortunate enough to have a dietitian in my office to help patients with that. We talk about a deck of cards as being an appropriate serving size. Sometimes it's easier to use the size of a fist, which can also be used. But we want people to start eating leaner meats because they're healthier. A caveat to that, a lot of people like the marbled fat meats because they tend to have better texture and they tend to have better taste. So as people cut back, they tend to add salt. And so one of the things we want to make sure we talk to people about is that they're not adding additional sodium to their diet as they're adopting healthier eating. And that, by the way, is something that's also important when we talk to patients about weight loss in general, because if you have a patient who's eating a lot of dietary type foods, the only reason those foods have flavor is because they're filled with sodium. So patients think they're being healthy by getting a diet meal when, although their calories may be reduced, their sodium content is usually very, very high. Next slide, please. We have our first poll question. And we'll wait here for the results. And what you can see here is that some people screen, which is great, and a lot of people do not. There's a number of reasons why people wouldn't screen. Part of it is you need to know what to do with the patient when you have a positive outcome, right? So we're going to talk about some of those things. And so if we can move on to the next slide, I think we're going to set that up and kind of move in that direction. So let's talk about food insecurity. Food insecurity is broken down in a number of ways. And here you can see from high to very low what that means. High food security is what individuals, whatever, they don't really have to worry about what they're eating. And at the other end of the spectrum, the very low food security, are individuals who have eating patterns that are disrupted because of a lack of money or other resources. Other resources is important because even if one has financial resources, but are in underserved areas, their access to the types of foods that we want may not be readily available, and we're going to get into that. Next slide, please. This is just visual. Everybody's a little different. I'm more of a visual learner, so I wanted everybody to be able to have this also in a visual form. And this just provides the same breakdowns as were on the previous screen and just allows you to reference it in whatever way works best for you. Next slide, please. So food deserts. So we have food security or insecurity. Is one able to obtain the foods that they want? But we also have food deserts. And these are individuals where geographically where they live, they cannot get fresh fruits and vegetables or other healthy foods. So for example, if you go into some of the communities here in Columbus, Ohio, which is very similar, I'm sure, to where many of you are from, there's no grocery stores. There's no farmers markets. So if you're going to get fruits and vegetables, the only option is to go to the corner store where there may be one moldy head of lettuce and 2 apples that are bruised. That is not obviously the fruits and vegetables we're talking about that we want individuals to be able to consume. So even if the finances are there, we still have to have people who are able to obtain the foods that we want. And in addition to the food desert, the area geographically around them, recall, especially for our Medicaid patients, transportation is an issue. So if they can't get to it by walking, there's a very high likelihood that they're also not going to be able to get there because they lack the transportation to do so. Something else I do want to mention is, remember, a lot of our underserved patients, whether it's a food desert or whether it's food insecurity, they have a life horizon that might be 3 or 5 days. Can I feed my kids today and tomorrow? Can I pay my bills next week? Can I pay my mortgage in 10 days? So when we talk to patients about consuming fresh fruits and vegetables and other healthy foods, it's important to understand what their barriers are, because some of us may look at it and say, you know, we need to do this so that 5 and 10 years down the road we're healthier. We have patients with a time horizon that is in days, not weeks or months or years. And so it's important to understand that as we work with them through this process. Next slide, please. So here's food deserts across the country. And you've got on the right-hand side how big of an area that problem is. No surprise in Ohio, the Appalachian area is an area of concern. And this is where you have no car and no supermarket. And so that's a more difficult place, as we've discussed, with respect to people being able to get to where we want them to get so that they're able to get the types of foods that we strongly recommend that they be able to do. Next slide, please. I've always found this interesting. You may not be able to get to a grocery store, but by God, you can get to a fast food restaurant. And that is really what a lot of the problem we also have is, because it's really easy for individuals to be able to get to that fast food, which at times, by the way, is also inexpensive. You can go get your $5 meal, which is a lot less expensive than going to buy fresh fruits and vegetables. One of the local chicken franchise is the one that drives me crazy, because with their ad, the whole meal's yellow, right? It is all starch, it is all deep fried, it is all fat. But patients can get to this. And so when you're looking to feed your family, and that really becomes the most important thing, and you can't get to the grocery store, your default may be to get to that fast food place. And that becomes a real problem. So to combat a lot of this, we all have our food banks, and that's important, but it's important to partner with your food banks. The example I'd like to use here in Columbus is Primary One Healthcare, which is a group of neighborhood health centers, and they've partnered with the food bank, and what they provide to the patient is a little scan card like you do for valued members when you go to the grocery store or any other store that you frequent. And so what has happened is Primary One Healthcare has actually made sure the individual qualifies, provides them the card, so when they go to the food bank already knows that that individual's been pre-screened. They scan the patient, provides them with the fresh foods that we want them to eat, but also allows the food bank to collect the data that they need to show that they're doing the type of work that is necessary, so that when they go out and talk to their supporters, they can demonstrate the value that they're providing. That's just one of many areas. These types of things occur all across the state, and that's just one of the examples of ways people may deal with that. Next slide, please. So I want to tell you about Aunt Bertha. Aunt Bertha is a way to look up the types of things, not just food, by the way, that patients may need. And so you just go to Aunt Bertha here, and I've got a couple of slides that'll show you this, and you pop in the zip code. Next slide, please. And that will take you to the programs that serve a particular zip code. And you can see across the bar that ranges from food to legal services to education to healthcare. And so by scrolling over the particular icon, next slide, please, it can show you exactly the types of things you may find in that category. So when you scroll over the food icon, you can look things up by food delivery, pantry, meals, nutrition, etc., which really helps you narrow down the focus as to what a patient may need. Most all of us have an EMR, so what we've done is we've just imported the link for Aunt Bertha into the EMR so we can automatically click directly into it for our patients. Next slide, please. And so when you click on something, you get a map, you get the information, it tells you how far away. And if your patient actually has electronic access, you can send this to them, you can forward it to them. So Aunt Bertha really works well. It's kind of like your in-exam room social worker, if you will. And social work, as everybody knows, is important, but not everybody has access to a social worker. So this provides you the ability to do that. Next slide, please. And I will turn it back over to Dr. Brzezinski.
All right, well, thanks. That was totally great, Randy. We have a good amount of time for questions. I don't know if Dr. Wexler and I both had a lot of coffee today. We're so excited to talk to everybody today. But so I think that was sort of the point of the session. So that's exciting that we'll be able to do that. So you should be able to chat your questions in if you have them. Usually there's a little button near the bottom of your screen where you can chat these questions in. And as they come in, we will review them and present them. As they're coming in, I have a couple of sort of draft questions that we can begin with. And so it's really a question to all of you to find out what you're doing to discuss the DASH diet or other dietary approaches, maybe simply salt restriction, in a way that addresses factors like health literacy among your patients. And I think we have Liz Beverly from Ohio University was going to share some insight about that with us. Liz, just give us a second while we queue up your mic here. Looks like you're good to go.
Hi there, this is Liz Beverly. And
Hi, I'm Sarah Adkins. I'm here with her as well.
so something that we do down in Southeast Ohio, this is Dr. Dave Drozik and Dr. Mark Richards came up with this, and they do the rainbow or the salt rainbow. So we're just going to describe what it is. And one thing that they do with patients is they ask patients to think about things that belong on the salt rainbow. And so they ask for example, they say, well, where do you think your salt comes from? And they'll say, think about white salt. Table salt. And then they'll say, well, let's think about some other sources of salt. And you say, well, what would be a source of black salt? And for example, they'll say soy sauce. And they'll say, how about yellow salt? Where can you get that? And they'll say yellow mustard. Then you can keep going, say red salt, ketchup or tomato sauces, blue salt, which can be a little bit tricky. Think of canned tuna. Purple salt can be drinks such as Gatorade or Monster or 5-Hour Energies. Green salt will be prepared frozen vegetables, particularly ones that have a cheese sauce or a cream sauce. Brown salt can come in baked beans or other canned vegetables. And then lastly, thinking about just other rainbow type things would be any processed frozen food meals or anything with colorful packaging. So that's what we've used with some low literacy, and it's had really great success.
Awesome. The next question I have is just maybe we're wondering what folks are doing around screening and addressing for food insecurity. And we saw, like, with the poll question, 29% of you said yes. So unless all of those folks who said yes are completely shy, some of you will have something to share with us. And I know that I think we have Dr. Shipra Singh from University of Toledo who volunteered to share some of what they're doing over there in the northwest corner of the state.
Hello, everyone. Good afternoon. This is Dr. Shipra Singh. I'm at the University of Toledo, and we have collaborated and joined in partnership with the ProMedica health system, and they have a food clinic intervention. And what they do is identify and red flag patients who are at high risk for food insecurity, and then they refer them to the food clinic where they have access to 1 to 2 days of food. And they are given services for nutrition counseling and other counseling that supports them. At University of Toledo, we are right now, we have submitted a grant to the NIH, which wants to investigate the association of these food clinic intervention that we have developed at ProMedica Health System and see their impact on health utilization and adverse health outcomes. So we hope to measure things like admissions, readmissions, ER visits, and also connect it to and see its association to total annual healthcare expenditures per patient. And hopefully share that those results and outcomes with everyone to show the impacts that we create in our community and in the healthcare system budgets and hospital readmissions and utilization, which has benefit for everybody, the corporate world and the community members. Thank you.
Shipra, that's great. Dr. Boland just passed me a question that she has.
I guess I could just ask.
And forgetting that the mic is in front of her. But so I think that one of the things a lot of us are curious about is like maybe the details of the process for how you determine someone is food insecure, and then how you flag that, and like how that information is shared across the care team. I think that's one of the challenge, like the on the ground challenges that folks face when they're trying to put together a program like that.
Right. So at the health system, we have identified 2 questions from the Hunger Vital Signs. They are 2 questions on prevention tools that identifies families struggling to access food. And those 2 questions are, we are worried whether our food would run out before we get money to buy more. And the Likert scale is, this was often, sometimes, never true in the last 12 months. And the second question is about the food that we bought didn't last and we didn't have money to buy more. And it had a similar Likert scale. These are well-validated measurement tools that are used in multiple settings where we are trying to understand food insecurities. And we have adapted this question to our screening tool.
Fantastic. It sounds like some really useful stuff is being shared. We're really glad that the folks at OU and Toledo are joining us to share this today. The one thing I'll say is like, so on behalf of both Dr. Wright and I, as far as team best practices and cardio goes, these are things that we would classify as probably emerging best practices for the state. So there are things that maybe we don't have like super rigorous trial evidence like what you're applying for at Toledo to support doing it, but we have some hints that this is something that could be an effective way forward that others might consider trying and evaluating. And I think we're eager to solicit and learn more about those types of emerging best practices. And in the meantime, we have a whole bunch of questions that have come in. I'm trying to weed through them. The first one is from and I apologize to folks. The names are sort of truncated on the screen, so the first one I want to highlight is from Metro Health, and it is Aunt Bertha linked to Epic, and I think this is a great question. So as somebody who is at Metro Health, I know that it is not. But I also do know that it is possible. And the other thing that I can say is we've begun to review this in the social determinants working group on team best practices. And so there are a number, so it's not the only solution, first of all. There are other similar sort of search and click resource libraries, and there are some phone services that do this. So there are multiple solutions and vendors. And I think if this is something that is useful, and it sounds like it might be one of the things that we focus on maybe in an upcoming ECHO session would be to consider highlighting some of the possibilities, including Aunt Bertha, and how folks are using them. I wouldn't mind handing it back to Dr. Wexler, though, and it looks like there's a question directly for him here. And this is whether it's the same as the AAFP's Neighborhood Navigator. And actually, they are sort of the same. What I will tell you is that if you click through to Aunt Bertha from the link that is in chat here, maybe we can provide this afterward, the AAFP Family Navigator, that they unlock some features that you would otherwise have to pay for. So that AAFP, via their relationship, has provided a few additional features that are not part of, like, you don't have to enter into a vendor arrangement to use them. But the tool is free. Like, you can go and use it just the way that he used it. And so, Randy, I don't know if you have anything else to add about how you're using it, or to sort of fill in on this question about integration with the electronic health record.
Sure. So you're correct. It's not integrated, but most people within their EMR can import their preferred links. So I've simply imported the link for Aunt Bertha into my favorite links page so that I can go to it when I need it. And so although it's not directly set up that way, it would require you an extra click or two because it's not directly integrated. You can talk to your IT folks about how you might bring in your own links, and I do it that way. And one of the reasons I do like Aunt Bertha is certainly the AAFPs has some extra bells and whistles, but I'm sure many people on this call are not necessarily AFP members. So we want to make sure that we have as much access as we can to that. But that's what I do. I bring in my links and I just create my own favorite link section and I just go to it that way.
Oh, so that's a great point. One other thing I'll just add to that is that I know, so we've looked into this a little bit on a couple of my own research projects, and you can, like, so organizations can contract with Aunt Bertha to do an integration with many of the most common electronic health records. So and it's a fixed one-time cost, so that if you're doing that integration once, it's sort of a big upfront cost, but then once it's done, and you pay sort of an ongoing fee to continue to use the service with your patients. So that is available from them and other similar vendors. So Sherry, I think you were going to highlight a question.
Well, I was just noticing that Liz was saying that she has a strategy at OU that they're using. So it might be just I know we don't have a lot of time left, but maybe we have a minute to unmute her and just hear what she wanted to
Yeah, that would be
share.
good. So let's hear from Liz, and it looks like we have a couple more questions, and I do want to relay Dr. Mysack's comment.
Hi, Sherry. Could you repeat again what it is that what you asked me?
We had seen the chat about that you guys had a strategy for addressing food insecurity. I didn't know if you had wanted to share that.
Oh,
that was earlier.
That was pertaining to the Salt Rainbow.
Okay, sorry. Sorry. Thanks. So I'll let you.
Sure. So actually, Sherry, I think this question might be best addressed by either you or Dr. Wright. And so there's a question about the extent to which the DASH diet could help persons with prediabetes or diabetes, and so its relevance sort of reaching beyond just blood pressure control.
Yeah, this is Jackson Wright. The DASH diet has clearly been studied with regards to hypertension. It's been known to prevent, it's even been known to be associated with lower cancer rates, a number of diseases. In terms of prediabetes, the major issue would likely be more related to the calorie count as opposed to the actual food ingredients. However, the DASH diet is a reasonable diet for patients at high cardiovascular risk, which would include diabetes and prediabetes.
Brenda Parks has a question.
Oh, great. So yeah, I mean, do you just want to unmute her and she can ask it? That would be great. So this is Brenda Parks. Brenda, go ahead. You should be good to go. Let's try that again. We didn't quite get you unmuted in time. Actually, we are struggling to unmute you. So if you want to type the question into the chat bubble, we'll give it a try that way. The other thing while we're
Wait, this is all once unmuted.
yeah, but it looks like there's some
She might be muted on her.
Yeah.
Oh,
Brenda, you might be muted on your side.
Yeah.
Because she has full control right now, and it's.
Brenda, are you able to unmute yourself? All right, well, while we're working on that, I don't know if you wanted to read Jim's comment, and then we might need to wrap up just because of the time.
Yeah, well, so I think it's so November 6th is coming. So I think that the Dr. Mysak from Metro Health has commented that one of the reasons we are even having a meaningful conversation about hypertension and cardiovascular disease in Medicaid populations in Ohio is because nearly 750,000 Ohioans who did not have any insurance are now on Medicaid due to Medicaid expansion, and that in particular there's a need to support the continuation of that coverage through the Medicaid program, because it's clear that individuals will not be covered by that program under some of the proposed changes. So that a reminder to sort of pay attention to what proposed changes are and contact your government relations group or directly your representatives and urge them not to limit that coverage for patients who are benefiting from it. I think that's all we have time for the Q&A.
Were you able to unmute Brenda?
And Beverly, we're gonna.
Brenda, do you want to unmute?
I'm
We
sorry.
unmuted Brenda. Brenda, are you able to say anything?
Brenda,
now?
we've got you. It looks like we've got it fixed, so we would be thrilled to hear your question.
I'm sorry, it's a bad connection. I don't have a question. I apologize.
Oh, well, it's wonderful to have you present anyway.
Well, and props to the tech team for getting your audio on.
In a car.
Oh, she's in a car.
She's in a car.
Yeah, all right, good.
All right. Well, thank you. I want to take a moment to thank Adam for helping us field all the questions and set the stage with the team best practices. And I want to really thank Dr. Wexler for being our keynote on this today and sharing what they're doing from Ohio State, as well as our other partners that shared today from Ohio University and University of Toledo, and all the great participation that happened today on this webinar. So I want to just take that moment to thank you. I think, in terms of highlights from our discussion, and I don't know if you want to go back one slide, Rick, if you're able to do that. I think just as a summary of all the great discussion that happened, really the DASH diet is effective in reducing blood pressure, and it's about equal to taking one extra blood pressure pill a day, so really important to do. And having the practical low literacy approaches can really assist patients in making those dietary changes. And we're going to have we'll obviously send out the slides, but we'll also have more resources coming available online as Team Best Practices works with our website to do that, and we'll share those with you and let you know that they're available through our email. So food insecurity obviously is a common problem, especially in low-income populations, and these emerging programs I think will be really helpful in assisting us to meet those goals. So on the next steps, I know we got to close up here. I just wanted to mention that we have a post-webinar survey but it's probably going to go out early next week. So just keep an eye on that, and you can mention new topics or new areas that you want to hear from us in the future. Dr. Constant, anything you wanted to say at the end?
No, just to thank everybody for being engaged with Cardio. We not only hope, but we plan to make a difference in the health of Ohioans. And a special thank you to the Ohio Department of Medicaid for supporting this program. So thanks to all, and enjoy the rest of the afternoon.
Thanks, everyone.
Thank you.
Thank you.